I'm Dan Hawkins with NAC, and with me is Tess Kuenning, who is CEO of BiState Primary Care Association, representing Vermont and New Hampshire, and all of the health centers in those two states today.
Yes, thank you.
Tess, great to have you here.
Thank you, Dan.
For this history lesson. So we were talking just before we started about how you got started, but before you began your field work, if you will, you were already a registered nurse.
Yes.
You had already gone to nursing school.
Right.
When you finished that training, what did you want to do at that point in your life?
So what I wanted to do was ICU and critical care nursing. That's what I thought
Really?
I was sort of destined for. And I spent 5 years doing that in tertiary care, and really loved the intensity of it, loved the math and the tinkering with sort of the blood gases and the medication, and I loved patient care. I loved the bedside manner and being with patients, but I felt like it was always just one individual that I was helping, and so I sort of had this thought that I wanted to get into more public and community health. So I did a total 180 and packed up my bags and headed to Asia for 5 years. I had intended only to go for one, and traveled up through the South Pacific up to Thailand, and met a friend of mine who we went to nursing school together. She was working at a Hmong refugee camp, and so I spent a month there with her, but I had already organized a volunteer job in Kathmandu in Nepal. So I went on from Thailand to Nepal, and then what was supposed to be sort of a year commitment to a small community health center turned into 5 years.
Wow.
Yeah.
And what drew you to Southeast Asia?
You know, I think it sounds kind of corny, but I was really attracted to the Sherpa. And sort of that whole National Geographic. I was always interested in travel, and thought it would be really amazing to go into the mountains. And so
Indeed.
I organized, found a not-for-profit organization, an NGO that had a small clinic right outside of Kathmandu. And then I went there to work, and then we built another clinic a couple-day walk north into the mountains. And then there was another clinic that was in what Nepal called a cultural sanctuary, where you had to be able to speak the language and adapt to the ways of the faith healers and the traditional birth attendants in order to bring your practice there. So we started a clinic there. It was either a 10-hour bus ride and then a 5-day hike, or a 10-hour bus ride and a 1 day and like a 3-hour flight. And the flights only came in on Saturdays. So if you missed your opportunity, you had to wait. And it was in a place of Nepal where there was no cars, no bicycles. So it was a Saturday.
Everyone traveled by foot, huh?
Only traveled by foot, right. So on Saturdays, people would come to see who came in the flight and what material they brought. And so we started a program there that was, it was a primary care practice, and we brought in providers. Our model was to teach the Nepalis so that we really were educators instead of actually doing the practice. We did a lot of the practice, but really wanted to leave behind a sustainable model. And so the model that we left behind there was an education for women in the village so that they could learn to be birth attendants. And that was really what my expertise was in, is maternal child health and birthing of Nepali women. And so what we did is we did a literacy program where if they graduated with a literacy program, they got a goat, and that allowed them to then
That was
have
their prize,
that
right?
was their and it allowed them to be sort of they are the economic drivers living in the village. They make the choices, many of the choices, but this gave them the ability to actually have a resource. So the goat milk and the cheeses that were made and the yogurts, and then
Wow.
eventually they would have additional goats, and then they would sell them off for the meat. So it became sort of an economic stimulus for the women, and they were really interested in learning how to work with the traditional birth attendants as well as the faith healers. So you never went to a Nepali birth without a traditional birth attendant or a faith healer. So my job was to teach the Nepali women and work with the sort of the cultural piece of Nepal. And I was chosen to go because I spoke the language and had the skill.
You did. You had learned it by then.
Yes, yes. So I was at the time quite fluent. I can do quite well in Nepali still, but it's been a long time since I've had the opportunity to use it on a daily basis.
So many parallels with my earlier life
Yes.
in Texas when I learned
Right. Spanish.
to speak Spanish,
Right.
etc. And I went down there for 1 year and stayed for 10.
Yeah, so I was only
There's
half
an
your time.
attraction.
Yeah, right. I met my
about 5
husband
years
in
is it?
Nepal, and so we moved back to the States, and we've been together for 35 years. So then he was in graduate school at Tufts at the Fletcher School of Law and Diplomacy, and so we moved to Boston after getting married, and then I worked for CMS. HICFA at the time for a year and decided that wasn't quite my thing. So then I moved to the U.S. Public Health Service, and at the time, the U.S. Public Health Service had responsibility for the community health centers, maternal child health, HIV/AIDS. So I worked as a public health and a nurse consultant for the U.S. Public Health Service.
And this was what time period?
1990 to 95.
Okay.
And then when I was working for the U.S. Public Health Service, I met David Reynolds and Ann Peters. And they were the two CEOs working in one community health center in Vermont, in St. Johnsbury in what we call the Northeast Kingdom, and then one community health center in New Hampshire. And they had begun this organization called BiState because they were only one health center in each of the states, so they collectively came together. And I think also their brilliance was that it wasn't just about health centers, it was about primary care. And so they had sort of a collective movement to bring in WIC programs, family planning programs, anything that was serving the moderate and low income families. And so they created BiState as a sort of a collective of organizations that were interested in the underserved and interested in primary care. And they received their first grant funding in 1995. And so then I came on as their first CEO in 1995.
And there were some rural health clinics
Yes.
in the two-state area too.
Right. And so the rural health, so we had rural health clinics, we had small hospitals as part of our, we had family planning, we had WIC, and the AHECs, which is now, the AHECs weren't the AHECs at the time, but they were doing education. And so that is still today part of the Primary Care Association.
Area health education centers.
Area health education
Are they
centers.
still around today?
They are. And we have a really good working relationship with them because they do a lot of the early learning for people who are interested in getting into the health professions.
Wow.
Planned Parenthood is a member of ours, as well as free clinics. So we still remain a primary care association, even though 22 of our members are FQHCs. And at the time, we only had 2 when I started, and we have 22.
We want to talk about
No.
that growth.
Yeah.
Because that is pretty phenomenal. You know, even though it's one relatively small part of America,
Right.
and it's a two relatively sparsely populated states,
Yeah.
you have on your watch the growth of health centers, both in the numbers and the numbers of people served,
Yeah.
has been phenomenal.
Yeah, it has been great, and I think part part of that sort of special sauce has been the relationship building. So it is a small state. Like New Hampshire has less than 700,000, and Vermont, and New Hampshire has like 1.2 million. So less than 2 million in both of the states. And they operate very differently. They're two very different states, both politically and sort of how they approach community health. But I think it was building those relationships with the state officials and with the governors and with the legislators that really drew the attention of what could happen. So if you were a patient in St. Johnsbury, you had access to services regardless of your ability to pay. And as we started to grow services, so not only just medical services, but the dental services as well, and more recently, sort of the mental and behavioral health services, we wanted to make sure that somebody in the southern part of Vermont had access to those same services. So there was a level of trying to bring equity to both Vermont and New Hampshire. And of course, we had very supportive members of Congress that we would work with, Senator Jeffords and Senator Leahy and Bernie Sanders, Welch have all been very supportive. Welch was in the State House at the time and helped us build like a roadmap in Vermont to keep bringing on new health centers. There was a law that was passed in Vermont to bring a health center to every county in the state.
I do remember that.
Right, so
I think you've almost achieved that, have you?
We absolutely have achieved that. And we see about 230,000 patients in Vermont. So 1 in 4 Vermonters get their care at a community health center, something that our Senator Sanders is quite proud of.
Yes, well, he should be.
Yeah, and then on the New Hampshire side, we worked with the state on trying to create a roadmap of converting a lot of the women's practices, so the WIC and family planning, into more comprehensive services. So we worked with them over a period of about 10 years to bring on new community health centers, about every 1 to 2 years. And the state actually then would help pay for some of the development, some of the support in terms of workforce and support for all the sort of foundational things that you would need, not only just the capital, but how do you recruit, how do you create bylaws, how do you create the administrative infrastructure, and the state in both Vermont and New Hampshire helped to support that, which has helped spur on then the ability for us to grow to 22 community health centers.
You've been a really Johnny or maybe Jana Appleseed, helping to seed the development of health centers. I mean, I would assume that a fair amount of your attention and time has been spent helping to develop the community groups into sponsors of health centers, and then to help develop those health centers and their ability to thrive and survive and function and meet all of the requirements, the so-called compliance requirements for being a community health center.
Yeah, I think
that's occupied a lot of your attention.
It has. I think the thing that has been probably my greatest achievement is finding really great staff. We've had some really bright, talented people that have come through the organization, and so that to me is, if we can sort of lay the foundation and then bring in people that actually can get out into the communities more. I tend to work more with the state legislature and the governor's office and, of course, all the federal work, but we have had in the past some really delightful people that have worked on community development and the making sure that we have the MUAs and the MUPs and the HPSA scores to be able to bring in a facility. So we've had some great, and the thing that I think is I'm probably one of the things I'm most proud of besides the staff is how the health center CEOs relate to one another. And so I think it might be because there are their own service areas. There isn't a level of competition. So like there's one health center in Manchester, one health center in Burlington, one
So it's
health center in Rutland.
collaboration,
It is
not
a lot of
competition,
collaboration, and they want each other to succeed. And so early on, they were sharing documents and sharing protocols and ways to bring sort of rise all the boats and making sure that they're all doing well. So we, out of that has spurred, we have a CMO group, so the medical officers come together. We have case managers that come together. We have the communication staff that come together. We've got the CFOs and the CEOs. So we have these learning teams that we've done, and some of them are just statewide because some of the laws and regulations are pretty unique to the health centers, but some of the things like the communication and the workforce and the CFOs, those are all both, you're right, they're both statewide. And so we've set up portals for them to be able to do it. We use Basecamp so that people can do communications. So we've allowed people to share this information and share their data and share how they're doing it so that they've all been successful together.
I love the fact that you, what is it, after 40 years from being away from Nepal, you're still focused on base camps.
Yeah, I am focused on Basecamp. Yeah, I am. I have, and I actually, when I go to some of the health centers and see Nepalis, there's a fair amount of Nepalis that have moved to as refugees. So some of them were from Bhutan. So they were Nepalis that went to Bhutan, and then the Bhutanese government decided to create just a only Buddhist country. So Nepalis are typically Hindu. So they had to actually migrate back to Nepal as refugees.
Wow.
And so the United States government resettled a lot of the Bhutanese refugees who are really ethnically Nepali and speak Nepali to many places throughout the United States. But Burlington and Manchester and Concord have been a place where many of them have come.
That's
so I
something
have.
You may have had a little to do with that.
Well, actually, I didn't, but I have been part of welcoming them.
I was going to say.
Yes, yeah.
Chair of the welcoming
Right,
committee.
exactly. Chair, right, yeah, vice chair maybe, but yeah, of welcoming them into our community.
Yeah.
And they bring a rich history. You know, just like the what happens at the community health centers. They really think about family. They think about whole person care. They think about using their faith as well in their own health. So they've been a nice addition to the community health centers.
Okay. That's all wonderful and good, but you had to have had some challenges
Oh, plenty.
over the past 20 years.
Yeah.
As you've.
Yeah. I would say part of the challenges have been the disconnect between federal and state law and sort of the ability to be able to grow the health centers in the early days. The Affordable Care Act, I think, was transformational with regard to the $12 billion that came and the $10 billion for advancing the community health centers and then some for capital. So I think in my early days in New Hampshire, there wasn't a lot of interest in programs that were funded by the federal government. So Medicare, Medicaid, even the grant program. It took a long time to seed that information into the sort of the politics of New Hampshire. But slowly we were able to bring on Senator Gregg. He was an ardent supporter of the community health centers, did a lot of earmarks for capital for the community health centers. And then when he left, his sort of successor was Kelly Ayotte. And Kelly Ayotte, I think, learned quickly from us and from Senator Gregg how valuable the community health centers are.
And became an early and ardent supporter
Of community
health
health centers,
centers, yeah.
right? In sort of in that bipartisan tradition of,
Yeah.
you know, and I think the way that they like it is because one of the reasons that they like it is because it's a small business. it's a small business that gets a grant to be able to do work, but they are small businesses and community owned and operated. I think that was something that they really appreciated, that
Yeah.
it was the community. And since our communities are so small, the senators, the representatives, the governors, they tend to know the people who are on the boards, and so it brings a level of legitimacy to that. And then we also worked with our chambers of commerce to and the New England Council, which is a sort of business-oriented organization throughout all of New England that we've joined as well, to demonstrate that we are businesses, right? We're in the business of healthcare,
Yeah.
and we're in the business of the social services, and we're in the business of helping people, but we are businesses. And so there are many things that they can do to help support us as businesses as well. So that's been good. One of the things that I think and I think it's going to be still difficult over the next few years coming in, are the fact that your footprint has to be really fairly large to be able to use your leverage. And so many of our health centers are small. You know, we have some health centers that are still seeing 4,000 patients. We have some health centers that are seeing, 15 to 20,000.
Yeah.
But they're all individual organizations, and so while they work together well, they're not networked in a clinical or a financial way. And so I think that is going to be one of our greatest challenges coming up, which is how do you create a larger collective footprint so that you use your leverage with many of the ACOs and the managed care companies that are coming to be able to negotiate
Not to get
better.
swallowed up by them. Right?
Exactly.
Yeah.
And I think that that's the fact that the health centers are sort of owned and operated by a board, and they're proud of their community, and their community is sometimes too parochial, too small, that we need to really think about expanding and really merging some of our health centers together in order for them to be able to be relevant in the new healthcare marketplace.
Strength in numbers for survival. I mean, it's
For survival, and
yeah.
it is survival.
Yeah.
It is survival. I mean, I was, I'll be one to say that I think the Affordable Care Act has been an amazing act that has changed people's lives, especially in terms of protections and coverage. But it also, came, the whole chassis of the ACA came to also reduce cost and to be able to network together. And so because many of the organizations, academic medical centers, many of the larger hospitals, they had the financial ability to be able to come together with other organizations. And so their capital, both in terms of patient population and assets, are so much bigger than our community health centers. And so in order for the health centers to really survive in the future, they're going to have to think differently about how they're doing patient care and how they're organized together. That's going to be one of the greatest challenges.
How do the other providers in the two-state area, the hospitals and others, get along with or not with health centers?
I think in the earlier years, it was much easier because the health centers would see anybody regardless of their ability to pay. So if hospitals or practices weren't getting a fair Medicaid reimbursement, the health centers had their PPS APM as a little bit more of a fair way of being able to provide all those services. So there was a willingness to have the health centers do the primary care. But in the shift of the Affordable Care Act, where really you're paid in a per capita way by attribution, by the number of patients or the number of lives, as they say, that you have, there is a huge interest of the hospitals to now do primary care. They want to own those lives. They want to control those lives. They want to control where they're going in terms of their care. They're narrowing their network in terms of where their patients can go. And I think that their interest now in doing that is I think less of an interest of the community health centers taking care of the patients. They want to own the patients in a way that they haven't in the
So
past.
now that's the competition that's
That is the
going on.
competition, right? And we're in New Hampshire. We're so aligned with the Boston market that in order for there's just a maturation of many hospitals that are, and even the ACOs that are happening in Massachusetts with their large district waiver. That's actually coming north and coming into New Hampshire. So the pressures of the health centers, what we call downstate in the southern part of the state, are highly competitive as opposed to the North Country, where they have their own ACO, and even as opposed to Vermont. So I think the pressures in the downstate of New Hampshire are going to be significant, especially when more resources are put into these district waivers and more resources are put into ACOs, that they will then be forced to, I think, make changes to adapt to the new marketplace.
Yeah. You have spoken of some of the challenges that you face. What do you think are your greatest achievements? Not just your, but BiState's and health centers as a group.
Yeah, health center in general. So not just ours, but in general. What drew me and keeps me in this movement is the people and how committed they are and passionate they are about caring for people in a way that's very different than just a transactional visit, that you'll see me for my blood pressure, you'll see me for this, but you'll see me for my whole person and who I am and who's in my family, and if I'm taking care of my elder father or if I'm taking care of a grandchild. And I think the people who are in this movement are in it for its mission, but they have understood that they need to be in it as a business as well. So it's that collision of both the mission and the business that I think is really great. And there's a quote that says, "There's nothing so unequal as the equal treatment of unequals," and I really believe that. That there are people who come into this world who need a little bit more.
Sure.
They don't have some of the resources that other people have. And so I feel like it's our job collectively to make sure that people who are in need have the resources to be able to bring themselves out of that need. And so that's something that the community health centers have done, and now almost 29 million people, largest primary care network in the whole United States. And what a great way for us to actually grow the health centers than working with the politicians to try to double the number of patients that we're serving.
Exactly.
Yeah.
It is rather amazing that I think back to my days as a Vista volunteer, and I'm sure that was your motivation in Nepal as well, to work ourselves out of a job, to literally hand the care system over to the community. And that's still a goal, but delivering that care on a daily basis is not something you can hand over to a machine or to some amorphous corporation. It's got to stay with the community. And that's what the health centers are. They are the community. They're in the community, they're of the community, by the community, for the community. And my view still today, 40 years later, is that the future for health centers is bright. Doesn't mean we don't face challenges and threats even.
Yes.
But the possibilities are endless.
Yeah.
How do you feel about that?
I would agree, and I'm encouraged that there have been some things that have happened in Congress to allow the health centers more flexibility, the added resources for the mental health and behavioral health and substance use disorder, medication-assisted treatment, that we actually can be there for emerging public health needs when there's a disaster for a hurricane or tornado, that the health centers are there. If there's Ebola or West Nile virus, or the health centers are on the front line. And so I think if they're seen as sort of the go-to for both primary care prevention and public health.
Yep.
And all the emergency pieces that go along with that, that I feel like they will stay strong for at least my lifetime, for sure. Yeah.
Yeah, we're not going to cede this before we leave this earth.
No, I would say not. I would say not.
Good. And we have good young, you've talked about it, you've spoken with pride of the folks you recruited at BiState.
Right.
But the other thing is the leadership at the local health centers,
Yes.
which is also strong.
Yes, and changing. So, I've been in the position almost for 25 years, and so the CEOs that were there when I first came, there's probably only 3 or 4 still left. There's been a real turnover of that staff, and so but the mission of that community has remained the same. So they've created a legacy that has allowed the community to be able to develop and grow, and I think that the future is very bright. If I think about just some of the staff that we've hired in the last few years to do some of the work, they're motivated, they're energetic, they've got great ideas. So I feel like that's where the possibilities are with the youth, and to then transfer our world to them and allow them to be creative and innovative. And I think Jim McCrae is now just talking about some work that they're doing with Deloitte about really thinking through a transformation of the visit, not just a transformation of the pathway in terms of coming in to register and then how quickly can you get back into a room and who's the medical assistants that's going to. That's a very different transformation. That's what's happening now, which is how do you actually do the visit? Do you do the visit on your phone? Do you do the visit, in
their homes?
In their homes? Do you use telehealth and telemedicine? Are you thinking about group visits for people? And so as the federal government and the state government change the way that the payment reform can happen so that you can get a revenue in for doing a group visit or doing a telehealth visit or seeing somebody on your telephone. That's a transformation that the health centers are going to have to make in order to stay relevant. And I think when you bring in the millennials and you bring in the Gen Zs, they're native to all of this. They understand it. They want to push us in that direction. And I think it's going to be something that's going to be quite helpful to the health centers in their survival.
Isn't that interesting, huh?
Yeah.
And the young shall lead us.
And the young shall lead us,
The
yes.
next generation.
Right.
So it's a bright future.
It is,
for health
it
centers.
is. And I have to say, you have been just an amazing leader and a mentor to me. And I've appreciated that.
Thank you. Thank you. Well,
I
you have been a phenomenal support source and leader in your own right.
Yeah.
And inspired me
Oh,
to
nice.
keep doing what I do.
Right. I find you an
So-
encyclopedia of information.
Mutual Admiration Society.
Right. But, just your history and helping us along the way with some very difficult times in Congress. And I think that steadfast, your ability to move on both sides of the aisle and your just the information that you have about why we would do it and how it's worked in the past and why it can work in the future, I think has been something that NAC should be quite proud of. And I have always appreciated you, and I, of course, appreciate your wife, who does amazing work in the Medicaid space and at George Washington University.
Thank you so much.
Yeah.
Well, thank you for all you do, too.
Oh, it's been my pleasure. It's been my pleasure.
All right.
I was afraid I didn't have anything to say.
We've kept it going here.
I think we did. I think we did.
All
Is there
right,
anything
sweets.
else?
I don't think so. I think that's it.
Okay, great, good.
Thank you.
Yeah, thank you very much. Thank you.